Hello everyone, welcome back to my YouTube channel, Nursing with Beatrice. So today we'll be looking at a topic which I have titled Hyperglycemic Hyperosmolar Nonketotic Syndrome, what we call HHNS. So today we'll be looking at what this condition means, the pathophysiology, the signs and symptoms, what you should watch out for, what causes this condition, and how to diagnose this condition, the management, nursing management with medication and all that, and important one, patient teaching to avoid this condition or how to cope with this condition. So let's begin. So hyperglycemic hyperosmolar nonketotic syndrome, HHNS, is a gradual life-threatening condition seen with type 2 diabetes, so common with type 2 diabetes mellitus. So the reason is due to insulin resistance. So, and that reminds me, for my one of my videos on diabetic ketoacidosis, if you have not watched it, you can go back and watch it so that you can see the difference between these two, because that one is sudden. There's no warning, but this one happened gradually over a period of time. Both are complications. So this condition is due to insulin resistance, so meaning it's common with type 2 diabetes. It's not like you can't see it in type 1, but very, very rare. So we're back again to insulin. What does insulin do? Insulin is a hormone that is secreted by the pancreas, the endocrine function of the pancreas, to convert glucose or take glucose to the cells where the body needs it the most. So because glucose is a major source of energy, is the fuel the body drives with, it's a major source. So in this condition, in type 2 diabetes, when there is resistance to insulin, the patient may get to a state where they develop this hyperglycemia, so high that the osmolarity of the blood, the plasma osmolarity, will be very high, greater than 350 millimole per kilogram. So pathophysiology, how does this happen? I've also break it down into some phases. So the first one is there's insulin resistance. So not that the patient does not have insulin produced at all, but the insulin there's resistance to insulin. The insulin is not being able to do the work. So because of insulin resistance, nothing is converting glucose, nothing is taking glucose to the cells where the body needs it. So because of that, there will be so much glucose that will be flowing. Remember, it happened gradually. So over time, glucose continues to build up in the body. So that we call it extreme hyperglycemia. I use the word extreme hyperglycemia, extreme because it's so high. It will be greater than 600 milligram per deciliter. In diabetic ketoacidosis, it's greater than 300 milligram per deciliter, but in this one, it's like almost times 2, greater than 600 milligram per deciliter. And so that's the second phase. So because of that hyperglycemia, of course, there'll be hyperosmolarity. So there'll be so much glucose in the blood, so making the blood so concentrated. So there'll be what we call hyperosmolarity or plasma osmolarity of the blood. Then the next thing is what we call osmotic diuresis. That's another phase, like the fourth phase. So in this one, osmosis is going to happen. So glucose, as it's being filtered by the kidney gets overwhelmed, and some begin to filter and escape through the kidney because they are supposed to be reabsorbed, but they will filter through. They are pushed out. As they are pushed out through osmosis, they are also pulling water along with it. Even some electrolytes like sodium, potassium, chloride may escape along. So because of this, the patient begins to lose fluid. Patient begin to urinate a lot. They begin to lose fluid, also lose electrolyte. As they are losing fluid, that will result to the fifth phase, dehydration. Patient become dehydrated with time. Because of this glucose that is so high, the osmolarity of the blood is high, and patient is losing fluids because glucose is also being lost through urine. They are urinating a lot, they get dehydrated. And that will lead us to the next one, which is the sign and symptom of this condition. So the first one is hyperglycemia, high glucose in the blood. So when they do the blood test, they are going to see glucose as high as up to 600 milligram or more. Then the patient will manifest signs and symptoms of dehydration. They will be weak. They will look dry. The skin, the mucous membrane will be so dry. There will be sunken eyes. You know, when you see their eyes, it will kind of as if it's in. So they feel weak, tired, and all that. Now, something unique about HHNS that may not be seen in DKA is altered mental status. in most cases it happens in this one. For DKA it may not, but this one is so common because of that hyperosmolarity. Get to a point where there's metastasis. They almost get into what we call diabetic coma. So these metastasis changes, they become drowsy and all that. So that can happen. Then another thing you need to know, for HHNS, you will not see ketone. There's no formation of no ketone in the urine, no ketone in the blood, because insulin is still there, just that it's resistant. So it's resistant doesn't mean it gets to a stage where the body begins to break down fat. All like DKA, where the body break down fat, that will bring a byproduct of ketones in the blood. So here, there will be no ketone in the blood, no ketone in the urine, so there will be no fruity smell, those acetone breath. You will not see it in HHNS. Now, the causes is basically due to illness or infection. And it happens, remember, type 2 diabetes is common with people, adults, unlike in DKA that's common with children because of type 1. So, and this one, in fact, the most vulnerable to this condition are the old people. In fact, because when they begin to check their blood or they are sick, already they don't even have good appetite before due to as they age. So now they are sick with infection and all that. Then this illness, they begin to develop glucose hyperglycemia in their body. They won't even know. When they do tests, they won't even notice because the glucometer may not even pick it because it's going to be so high. So that's a warning sign. So it's common in people, older people, when they have illness, they have infection, or they are not treating or managing their diabetes properly. They can result to this HHNS. So to diagnose this condition, I mentioned it before, the serum or plasma glucose will be very high. It will be as high as greater than 600 milligram per deciliter. Then the plasma osmolarity will be greater than 350 milliosmol per kilogram. So it will be so high. The blood will be very concentrated. And then notes, I put it here, urine and serum ketone will be negative. So that's unique about this. There will be no ketones at all. But these two will be very obvious. Now, how do we manage this condition? It's still going to be like the way we manage DKA. We are going to fix the problem as they occur. So we're going to rehydrate the patient because they're already dehydrated, so they need fluids. We need to replace fluid. We place them on isotonic solution based on the prescription by the doctor. So the doctor may prescribe normal saline. So we load the patient, we begin to give the patient normal saline, but first we give like bolus to quickly rehydrate, and then we begin to titrate and give gradually. So while we are giving these fluids, we want to prevent, the reason part of it is also to prevent hypoperfusion of vital organs like the brain, the heart, the kidney, because we know that the blood volume, when the patient is dehydrated, the blood volume decreases. Plasma volume is also decreased. And when the patient plasma volume decreases, then it means the blood volume itself is low, so it may not get to those vital organs. But when we give IV fluids like normal saline, which is an isotonic solution, it stays in the intravascular space, which is where we want it to be. So it's not going to shift from intracellular to extracellular. No, it expands intravascular volume. As it begins to expand it, the blood volume increases, and then those organs can be well perfused. So it's very important. So while we are rehydrating with fluids, we are also decreasing glucose. We are decreasing glucose because of hyperglycemia. Remember, there's extreme hyperglycemia. So part of our management is to reduce glucose. And to reduce this, we're going to titrate the patient with insulin. They may prescribe bolus, and then we give it, and then we're going to titrate. We titrate gradually. We don't want the glucose to drop suddenly. So we put insulin, we give insulin in a continuous IV drip to titrate and lower those glucose gradually. While we are doing that, if the glucose drop below 250 milligram per deciliter, we want to, if the blood glucose drop below that, we want to give glucose. Though it looks like the patient have high glucose, why are we giving more glucose? Because we don't want sudden drop. We don't want to drop or reduce that glucose suddenly to prevent the risk of cerebral edema. Now, also part of the fluid we give at time based on the prescription, they may also prescribe hypotonic solution like 0.5% normal saline, so like 0.45% normal saline. But when we are giving that, we give it with caution, because if the fluid the fluid shift, because in a hypotonic solution, there's going to be a fluid shift into the cell. So because of osmosis, where fluid is moving from a region of lower concentration to a region of higher concentration. So if the fluid moves too much into the cell, it can cause swelling of the cell. It can also cause swelling of the brain because the fluid can move and mix with the cerebrospinal fluids, and then the brain becomes swollen and can lead to increased intracranial pressure. So we are careful not to decrease the glucose suddenly because of this. And when we are giving hypotonic solution, we also give it with care. Now we're also going to replace potassium because potassium may be lost. So usually, initially, the potassium will look as if it's normal, but as you start giving insulin, the potassium may drop. The usual range is between 3.5 to 5.2. But we want a situation before we even start titrating insulin, because it's going to push the potassium back into the cell where the potassium is more prevalent. Is going to reduce the potassium in the blood. So they'll be having hypokalemia. So because of that, whenever a patient is being titrated with insulin, we are monitoring the potassium level closely. At least the potassium should be within normal range, or at least up to 3.3. Before we continue to give insulin, we keep monitoring. We place the patient on a cardiac monitor to monitor those electrical activities that is going on. And our goal again is to prevent cerebral edema. So we don't reduce the glucose suddenly. And when we give hypotonic solution, we give it gradually. We monitor this patient closely to make sure those mental stuff, everything returns back to normal. Now, patient teaching also very important. So we teach the patient, these people, how to prevent this from happening. One, when they have any illness or disease and all that, they should seek for immediate treatment. And they should not skip their medication, because some of them are on anti-diabetic medication. They should not skip their medication. They should try and eat the usual way they eat and take their medication, not because they are sick then they don't want to eat at all, and or they eat now, they don't want to take their medication. They think that, oh, because I'm sick, maybe my insulin my glucose is not going to be much. No, they take their medication and they monitor their blood glucose very well. So we tell them a red flag when they test their blood glucose using a glucometer and they see that they are seeing very high value, or they can't even see the reading. It's a red flag that glucose have been so high, because it happened gradually. It's not going to happen suddenly. But HHNS can be very dangerous, but it's more difficult. They don't easily diagnose it because there's no that fruity breath and all that. There's no metabolic acidosis, unlike in DK where they easily catch it and so, oh, this is the condition. But this one, they may not easily catch it. So we teach them, because it develops gradually. We tell them, don't when you are seek for immediate care, and when you notice that you are not peeing more than enough, like more than usual, you urinate too much, you feel too thirsty, in fact, when you see that your body is not the usual way it is, quickly consult your healthcare provider. Let them evaluate you to be sure that your glucose is still properly managed. So that wraps up today's topic on HHNS, hyperglycemic hyperosmolar nonketotic syndrome. If you find this video helpful, please, I want you to like this video, share this video to others, especially to nursing students, and subscribe to this channel for more videos to be produced. And if you have a particular topic, you are confused, you are in nursing school, you are preparing for NCLEX, you would like me to quickly touch on, please leave a comment so that I will work towards that. Thanks for watching.